Thank you very much. So, take-home message from this talk is going to be that both accuracy and precision for LV volumes and ejection fracture differ between both the imaging modalities, the acquisition methods. For example, I'd like to use 3D for echo, for example, if you're going to be quantifying volumes in EF. And of course, the analysis methods, and we'll go into the details of that. And then, once we've accepted these aspects, I'd like to sort of pivot the focus to talk a little bit about MAPSE, which has been a little bit underappreciated as a measure in the echo community and in the general cardiac imaging community. And it turns out that MAPSE beats the pants off of both LVEF and GLS for prognosis. And we'll get to that, to more about that. And MAPSE can be measured, as you know, effectively in every patient. So there's an argument to be made for rethinking the utility of MAPSE moving forward. Let's start with the different modality comparisons. Here we have, typically many studies will use cardiac magnetic resonance as the reference method, and here we have different modalities in their comparison to CMR in a meta-analysis robustly populated with over 7,000 patients. And what we see here in this figure is on the vertical axis, we have the difference between a given modality and CMR in percentage points of EF, and the mean value, but also the 95% limits. So the important things here are two things. One is the difference where the mean value falls, but the other one is, and possibly more importantly, the width of the error bars, the precision, if you will. A precise measure will have tight error bars, and a less precise measure, a more variable measure, will have larger error bars. So we see, in comparison, CT hits the spot almost exactly on the mean difference. The precision, the accuracy is there, and the precision is good. 2D echo is not that bad, especially when you add contrast to it, but the precision is lacking with the very large margins of the 95% limits. 3D echo, however, gets back to a precision and accuracy which very closely mirrors that of CT. SPECT has a tendency to overestimate the EF slightly. Still, it's less than 5 percentage points, but with slightly larger margins of the limits, as well as multi-gated nuclear radionuclear angiography for doing EF. Similarly, has a slight overestimation and larger limits. So even within echo, we see important differences. Here's an interesting study where they did both 2D without contrast, 2D with contrast, 3D without contrast, and 3D with contrast. And as you can see, the accuracy compared to CMR for LVEDV is at its worst, with almost 60 milliliters mean difference, an underestimation by 2D echo, and approaching closer to 20 milliliters underestimation with 3D plus contrast. So 3D plus contrast gives you the best absolute volumes, and then when it comes to EF, both 3D with or without contrast give effectively the same results, and then much larger differences when it comes to 2D, regardless of the contrast. So in summary, if you're going to be using echo and you want to get as close to the truth as possible and you want to get it as precisely as possible, you should be at least doing 3D. And if you're concerned about volumes, you should probably be adding contrast. Now, comparing some other methods out there, specifically SPECT versus cardiovascular magnetic resonance. This slide hammers home the importance of the choice of analysis method. It's not just the acquisition method, but the analysis method. And here we'll see 1, 2, 3, 4, 5 different SPECT analysis methods and their comparisons versus MR in the same data, the same SPECT data. The same acquisition, identical acquisition, just different analysis methods. And as you can see, the majority of methods vastly underestimate end-diastolic volume. One of the methods gets a bit closer. And systolic volume the same, with even larger margins of the limits. Ejection fraction gets it pretty well for most, but some of them are as many as 20 percentage points in overestimating. and then left ventricular mass, which is not a functional measure, but it sort of illustrates the difficulty. If you don't even know how much myocardium there is, if you're going to track it over time, it might be difficult. And this one method that was presented as by the authors as the new method did quite well, both regards to volumes for EDV, ESV, EF, and mass. But still, there's a sizable error bars, and the precision is a challenge. Another comparison is that versus the multi-gated acquisition or radionuclide angiography, where they use a blood pool radio tracer and planar acquisition, so a single plane of acquisition. It might look something like this. Here we have a region of interest covering the left ventricular blood pool from a planar acquisition in, I believe this is end diastole and end systole, and here we see all the frames over time, and you get the percent difference and you get the ejection fraction. Now this has been compared because in the world of cardio-oncology, the oncologists come from a tradition of using MUGAs because they used to be the only game in town back in the beginning of the importance of monitoring cardiac function. And here we see these are a slightly unorthodox way of presenting the data, but from the top to the bottom of the error bars is the 95% confidence limits, but the mean differences are seen in these small black dashes. But here you see 2D echo getting pretty much similar to MUGA. You add harmonic imaging on that, and it's fairly similar. You add contrast to 2D echo, and your limits become smaller, your precision is better. 3D echo is fairly decent, and then compared to CMR, they have a lot of variability there too, not necessarily due to the CMR, but maybe due to MUGA. We're not exactly sure when we're talking about what is the reference method. Here, the reference method is MUGA. You could turn it around and say the reference method might be arguably CMR, but you would also have varying results from very tight limits of agreement to quite large. So different modalities within echo compared to MUGA have the different modalities in general compared to MUGA have different performances. So then it comes to the machine learning, the impact of machine learning on quantification. And not surprisingly, in this recent paper in the Journal of Cardiovascular Magnetic Resonance, the humans have an intra-observer variability. The same person doing something twice will not do the exact same thing, and not surprisingly, the machine doesn't have a variability. That's by design. We know that the machine does the same thing each time. However, the really important part is the scan-rescan variability. So here they took a data set of over 100 patients, and they scanned them twice. So there was 2 data sets, 2 acquisitions of the cardiac MR, and then they did the analysis. The same human did it on each of the scans, and the same machine did it on each of the scans. So now it's sort of a fair comparison, because the machine, even though it'll behave the same, it's variability from one scan to the next. And as you can see, it reduced the variability, for example, in EF, the coefficient of variation going from around 6 to around 4. And why is that important? It doesn't seem like a huge difference, but in fact, if you're going to do a scientific study where ejection fraction is your primary endpoint, such a reduction in the coefficient of variability achieved by machine learning will give you a 46% reduction in sample size, which is an important component of planning a study, because you want to have not necessarily need to enroll more patients than necessary to achieve your primary endpoint. So this is a summary table across the different modalities for looking at volumes in EF. We have 2D echo, 3D echo, CT, SPECT, or PET. I lumped them in together, MUGA and CMR. And this may not be the perfect truth. For example, cost is something that is a little bit arbitrary. It's more of a business decision necessarily than anything else. But in general, echo is less expensive. CT and MUGA are more expensive. SPECT, PET is more expensive than that, as is CMR. So there is a cost gradient, but it's more driven by business decisions and supply and demand, maybe. Ionizing radiation, obviously, we don't have in the echo and MR space, but in the nuclear space, we have ionizing radiation as well as with CT. The requirement for contrast, well, 2D echo does not require contrast, but if you do want to get increased accuracy and precision, it would be advisable. CT, you absolutely must have contrast. You can't do a CT volumes in echoes and ejection fraction study without it. Temporal resolution, you have very high temporal resolution on the echo side, lesser on 3D echo and CMR, and even lesser than that for CT, SPECT, and MUGA. But the fact of the matter is that the temporal resolution is not the limiting factor. If you can get somewhere in the order of 16 to 20 timeframes, which you can get in the nuclear space, you can certainly get it accurate enough. And the big problem is not the accuracy as much as the precision and addressing the variability. Availability is highest for 2D echo. I'm putting a little bit less for 3D, just because you need to have the hardware and software to do it, and maybe even the staffing competence and knowledge. CT is reasonably available, as is SPECT, as is MUGA, and MR probably the least available. And the accuracy, we've looked through that data. They all have decent accuracy, CMR perhaps the best. But the precision is where it's really important, and the repeatability. 2D echo is the weakest link. 3D echo it does really well, as we've seen, as with CT. SPECT and MUGA not so much, sort of intermediate, and MR possibly the leader there. And the main limitation of 2D echo being image quality, as with 3D, the contrast and radiation for CT, the radiation and the precision on the SPECT side, as with MUGA, and then MR has the limitation of devices. So that's a little bit of an overview of how our imaging modalities behave for volumes and EF. Now, I'd like to pivot to talk about some other measures of left ventricular function. In this case, let's talk about global longitudinal strain. So global longitudinal strain associates or has a correlation with many of the measures that we can measure in a study. We can measure the mitral annular plane systolic excursion, MAPSE, LVEF, end-systolic volume, end-diastolic volume, mass, left atrial end-diastolic and systolic volume, left ventricular stroke volume. They all relate to GLS. There's an association there, mathematically, if you will, and geometrically. So GLS, I like to understand the performance of GLS, and that has become very lauded for its prognostic significance, is that it is a composite measure that pulls together all of these measures that we know have an established prognostic association. And it sort of composites them into one number, and that's how I come to see, from my mind's inner eye, why GLS is so good. But MAPSE is absolutely dominating, understandably. So it turns out that when you put it head-to-head, MAPSE compared to global longitudinal strain, ejection fraction, global longitudinal shortening is you just look at the percent shortening of the left ventricle without looking at the myocardium as such. And you see that MAPSE sizably outperforms all of the other measures head-to-head for its association with heart failure, hospitalization, and death. And this is in a cohort coming out of Pittsburgh, where we did the analyses with MRI, but it could just as well have been done with echo, albeit with slightly more measurement variability potentially. But I think the main importance here is that these associations and maybe the relative strengths, I would argue, would be the same results if we did it with echo. And this tells me that MAPSE has strong information in it. And it may be that we don't have that much advantage of doing the fancy strain package when you can just take an M mode or maybe even just a caliper and measure the movement of the mitral valve plane. And you see here a dose-response relationship for the survival association for MAPSE. As the worse MAPSE gets, the worse the prognostic association. So what about MAPSE and echo? Well, we know that back in 1986, they were already doing M mode measurements of MAPSE, and 88 they brought out normal values for age ranges, and so it's not something that's not been known, but maybe it's fallen a little bit to the side of the curb and not been studied in the prognostic studies, because everybody's thought that, oh, we need to do GLS. When you think GLS, think maybe it's just as good to do MAPSE. And you don't necessarily have to have acquired M mode at the time of acquisition. You can do anatomical M mode or measurements based on 2D images after the fact. Here we see the anatomical M mode of the MAPSE measured in multiple slices. And they established out of the Hunt study in Norway, recently published in 2019, the normal values and lower limits for men and women of different ages. And so these values, I would say, if you have an echo machine that's doing 2D images and you want to measure MAPSE and know if it's normal or not, you can pull that normal value out right now from this publication. Furthermore, we can trust that MR and echo show the same thing. The study's been done. Here we see on the horizontal axis, echo MAPSE in millimeters. On the vertical axis, CMR MAPSE in millimeters, and the Bland-Altman with minimum bias and low precision, or high precision, low variability. So we don't have to, we can interchangeably use these numbers. I mean, MAPSE has been done by all kinds of methods. Even back in '86 when they were doing it with M mode, they did it with planar scintigraphy with thallium. Here we have the end diastolic and the end systolic gated planar scan. They subtracted it and measured MAPSE on the subtraction images, which is amazing that they were doing something like that back in 1986, as well as, of course, now doing it for the gated CT studies, analogous to the MR studies. You identify the mitral plane and its distance from the apex, and you measure MAPSE, or also, in addition to that, global longitudinal shortening, which is just as good as global longitudinal strain. So maybe most importantly, MAPSE can be measured when the LV is difficult to visualize. So this is an image that might not be all too unfamiliar for members of the audience. What is going on in the apex here, we can't really see, but we can certainly see the mitral annular plane. I think we saw some of the presentations earlier with and without contrast. Sometimes the only thing you can see is the annulus, and it's moving back and forth. And you can certainly measure that, even though you can't see any of the chambers or the myocardium beyond that. So I find that working in the ICU and doing ICU echoes, it's particularly advantageous because there's nearly nigh a patient that cannot have their MAPSE measured. And it seems like it's a measure that gives prognostic significance, and we have normal values for it, so it might be something we should consider reintroducing if you're not already doing it. So in summary, both accuracy and precision, how variable is the measure, are important for looking at LV volumes and ejection fraction. They do differ based on imaging modalities. Mostly they differ in precision. They certainly differ for acquisition methods within a modality. I would encourage you to be using 3D echo if you can, as well as the analysis methods, as we saw with SPECT. The exact same image acquisition analyzed 5 different programs give 5 markedly different outcomes. And then if we pivot out of the LV volumes in EF, maybe we shouldn't be measuring EF as our outcome. Maybe we should be measuring MAPSE, and there's certainly data to support that. And it beats the pants off of LVEF and GLS for prognosis. So, and as we saw in the example, MAPSE can be measured in effectively every patient. So it might be worthy of considering once again. And with that, I thank you for your attention.